And it says we're live, but let's just double check it real quick because my Zoom and my Facebook we're good. We're happy today. Good morning, everybody. It is Lisa Salberg with you here today. It is Tales from the Heart, brought to you by the Hypertrophic Cardiomyopathy Association. And today my podcast buddy is Dr. Patient Alex Feria from UPenn. Good morning, Alex. How are you today?
I'm doing great. How are you, Lisa? Sorry I was late.
It is understandable. I reached out to Julie on our team. I'm like, you want to pop Alex an email? I'm like, he's early career. He doesn't have like 4 admins running around after him with a schedule. It's probably on his cell phone and he's busy. So that's what happened, right?
These are all my assistants. They're right here.
Yeah, the fancy life of a doctor, right?
Mm.
You're doing everything. Okay. Well, as you know, here on Tales from the Heart, a podcast from the HCMA, we talk about all matters related to HCM, and we have themes of the month. If this is your first time with us, welcome. If you're a frequent listener, welcome back. What we're trying to do here with the podcast is raise awareness, educate, engage the community, and really kind of bring everybody to information in the manner in which they want to hear it. Some of you want to listen to a podcast, some of you want to watch a webinar. We'll do both. So, Alex, the themes of the month for March for us are arrhythmia management and life with devices. So I thought I would talk a little bit, as we tend to do, both from the doctor side of Alex and the patient side of Alex. So
Sure.
I know my burden with arrhythmias was just a mad amount of PVCs and a lot of NSVT, which feeling those arrhythmias were very different. Not knowing quite when they would pop up in my life was a little unsettling and makes it a little hard to, predict what you're going to be able to do in a day. I can tell you that I had many meetings where I would be sitting there doing my work and I'd be like, I'm going to need to step out for a second and go through your little moment, get yourself back to zero and rejoin life and pretend that what just happened didn't happen. Does this ring any bells with you?
Yeah, I mean, it's interesting with the abnormal heart rhythms that are associated with this disease. Some, and it's different for everybody, but some people know exactly when they have some sort of rhythm, and they can tell you at 3:30 p.m. on this day, I started feeling bad and I stayed feeling that way. Other times it's just sporadic skip beats that are, most people are what I say to my patients, because a lot of people never even heard the term palpitation. And so I say, it's more of an uncomfortable awareness of your own heartbeat. Most people don't even think about the fact they have a heart. But every once in a while, when you have these skip beats, this like uncomfortable thud that almost leaves you with this like emptiness feeling that then the next beat is even harder. Those are palpitations. And sometimes people feel those, every single one, and they're incredibly uncomfortable and they can have a burden on your quality of life.
I found
so
them
those,
mostly distracting.
yeah,
Wasn't I being afraid of them because they didn't kill me the last time? I
yeah,
just find them distracting because now I'm not thinking about what I was thinking about. I'm thinking about, is my heart going to do that again? Is this going to turn worse? What's going on?
yeah. And I also, make sure patients realize that just because they don't feel abnormal rhythms doesn't mean, oh, I don't have any of those. I don't need to get checked for abnormal rhythms, because some of the scarier, life-threatening rhythms you will not feel, and you cannot feel. And that's why we're constantly, if you go to a center of excellence, they're going to be doing rhythm monitoring every year, looking for those, because you won't know them when they're coming. And so those are like some of those non-sustained ventricular tachycardias, or NSVT. Most people don't feel that. And so that's why we monitor for those.
So let's say, I'm going to stick with ventricular arrhythmias for a moment. I'm going to break this up. Bottom part of the heart arrhythmias, ventricular arrhythmias. We'll talk about atrial arrhythmias in a moment. So why are they important to know what kind they are?
Yeah. So the way, usually I'll draw at the heart, and when I'm sitting in the room with the patient, kind of point out where the thick muscle is, which tends to be in the septum of the left ventricle, but it can be in different parts. The thick muscle can have scar in it, and that we know that scar doesn't conduct electricity normally. And so sometimes that abnormal conduction of electricity can just be little sporadic beats. That's what translates to us as skip beats or premature ventricular contractions, or PVCs. Sometimes instead of being one skip beat, you can have multiple skip beats in a row. And they can go really, really fast and last up to like 15, 20 beats. And those tend to be what we call non-sustained because they don't continue. Ventricular because they're coming from the bottom chambers, and tachycardia because they're fast. Those are the ones that, we have good evidence that the faster, longer rhythms like that you have, and the more frequent you have them, the higher risk of having a life-threatening rhythm, like a sustained ventricular tachycardia, can then come from that. So that's what we're looking for. Because we're not good at predicting when a non-sustained rhythm is going to become a sustained rhythm. So as soon as we see non-sustained abnormal rhythms from the bottom chambers of the heart, that gets our attention, and we start looking for other risk factors to determine, do you need to be protected by a defibrillator?
So let's just talk for a moment. What are some of those other risk factors, and how did they evolve?
Yeah. So, risk factor has kind of modified over time. Initially, we talked a lot about the things that were easy to get in the patient history, sitting in the room with them. So, what's your family history? Has anybody died suddenly? That sounds like it's cardiac in nature of a young age. And, we really try and probe with those kind of questions. I don't think asking someone, is there any family history of sudden cardiac death from HCM is a super helpful question.
Very few people would read that question accurately.
Yeah, but a lot of times people come and say, "Oh yeah, Uncle Johnny died of a heart attack at 27." Huh, that's pretty atypical to have a heart attack at 27. Tell me more. Like, well, that's what we were told. And and I hear stories like that all the time. And if it tends to be on the same side of the family, recurring in multiple generations, that really makes you concerned that this could not have been a heart attack, but maybe something else. Or, family history of that same family member failing a physical exam or screening for the military, things like that should all start to poke, up questions about more in-depth heart history. But yeah, so family history of sudden death at a young age is concerning. In yourself, history of passing out. And we really try and dig deep into the circumstances around passing out, and that can be challenging. Some doctors feel very confident that they can say, oh, this was passing out because you had an abnormal heart rhythm, and oh, this was passing out for some other reason. It's usually pretty complicated to figure that out, but sometimes there's a couple of specific things like, I gave blood and got really lightheaded and felt like I was going to pass out. Those tend to be more triggered, what we call like vasovagal type episodes. But really concerning passing out, patients with HCM will tell you, I was walking and then all of a sudden I woke up on the ground. And in some instances, usually when you're lightheaded and you feel like you're going down, you try and brace yourself. When I've got patients coming in with a black eye and it's clear that they didn't even try and catch themselves on the way down, that's very concerning for an abnormal heart rhythm causing you to pass out. Regardless, I take all passing out very seriously. And that's something we want to
know. Excuse me. I've been able to use a recent socially shared event explaining the difference of, oh, I feel like I'm going to pass out. When you have the option that I'm going to sit down or fall down, those tend to be hemodynamically triggered, right? Like you're obstructed, you're dehydrated, you have a second to sit down. Well, you go back to look at what happened with DeMar, different cause, chest blow, but that just tipping over and you're down.
Yeah.
That's the ones we really worry about.
Yeah. Those videos that you'll see of players on the field dropping, most of the times they're not trying to brace themselves when it's cardiac. They're going straight down. And that's because it's usually due to an abnormal heart rhythm that does not squeeze blood. And so you're not getting blood to your brain's not able to react. And so you just go down. So, syncope or passing out is concerning. Another risk factor is how thick your heart is. And so we have good data that, with HCM, the current definition says that if your heart is about 1.5 centimeters thick or more, then that would meet criteria. Unless if you have a family history, then we get a little bit more conservative. But we know that if your heart is like greater than 3 times the normal thickness, then that can be associated with more scar and can also increase your risk for abnormal heart rhythms. And so, the combination of family history, passing out, really thick heart, and then abnormal rhythms on a monitor, and then the more recent advances have been in imaging. And so, MRIs, if you're an HCM patient that's never had an MRI, I pretty much get MRIs on all my patients. And it helps both identify truly the anatomy of the heart, but then we get to see how much scar is in your heart. And that, with work from the Marins, kind of helped elucidate how we quantify scar. And that's been a big game changer in terms of figuring out risk too. So additive risk from
I'm gonna
that.
pause you on that topic because it's an excellent topic and one that I've been speaking to Marty and Chris Kramer about a great deal. And I know I sound like a broken record sometimes, but there's reasons I'm broken on this track. Center of Excellence Care matters. How people quantify scar and what they define as a lot or a little is still variable. Within
100%.
high volume centers, we're talking a very similar language, but I've noticed a big problem with community MRIs, and that is interstitial fibrosis, so that it's like fibrosis, not quite scar yet. Those words can be interchangeable, but they're different. And if you're measuring all the interstitial fibrosis and not the dark scars, the burden can look higher. I had one person who said, one center said 28%, and another HCM center said 6% scar. That's the difference between getting a device and not getting a device. So go to if you're not sure, please have a high volume program, reread your imaging, and make sure your scar burden is what you think your scar burden is.
100%. And so I'm an imager. And so when I have patients come see me that have been evaluated at other centers, I always have the imaging sent to us and we reread the MRIs at our institution.
Okay, completely unscripted. How often is it underestimated versus overestimated?
I had one go from 9 to 19 in our read the other day because I looked at it, I was like, whoa, that looks like a lot of scar, and we requantified it. And so I would say I've had it go both ways, but I have definitely had a lot of discrepancy. And so, when you're dealing with something that's going to push you in one direction or another for putting a device in someone, that's, in my opinion, not something that should be just taken as gospel, whatever is written on a report. That we should be looking at all the imaging and quantifying everything in the same way in a standard format. Because otherwise, well, first of all, there's discrepancies between centers. And then if you're not doing that in your own center, then you can't track progress in terms of scar burden. Some people don't have a lot of scar when they're young. And then over time, for whatever reason, scar develops.
Yep.
And so I just think it's important to make sure that when you talk to your doctor, that they have viewed the images, that they've run over them with a radiologist. If you're thinking about this is going to be what's the decision between you and getting a device, because it can be the tipping point.
Absolutely. So what other risk factors haven't we talked about? We talked about mass hypertrophy, family history, scar burden, NSVT. What other things do you look at as risk?
They're also, depending on specific, and I feel like a lot of times the poor apical HCMs don't get the shout out, but apical HCM is quite common too. I see a lot of apical HCM, and that's where the tip of the heart is thick. And so one big risk factor for those patients that a lot of times does not get seen until you do an MRI, because it's very commonly missed on echoes, is aneurysms, where the tip of the heart dilates and balloons out. because you have that thickness, and then all of a sudden you just essentially have a layer of scar at the tip of the heart that sticks out. That's another risk factor, independent risk factor for abnormal heart rhythms that will push me over too. So those are a couple things. I'm trying to think, what else have I missed here? Wall thickness. And if you look at the risk scores, that's another, I think, important thing. Sometimes your doctors will talk to you about specific risk scores. That one comes from the European Society of Cardiology. There's also an American version of the score that look at how thick your heart is, how much obstruction you have, how
Left
big your
atrial dimension, yeah.
left atrial dimension. I personally think some of those scores need to be updated because some of the things that we used in those scores are not really used clinically anymore. Like the way that they put in left atrial dimension is not how we report it most of the time. But there are scores like that they shouldn't be the deciding factor, but they can help guide decision making because they essentially give you what is your overall risk over the next 5 years of having an event that could be life threatening. And so it helps guide a conversation, especially for people that like numbers and percentages. What I would say is that those scores don't include some of the newer evidence from MRI, like scar burden, apical aneurysm. And so keeping that in mind is important too. But those, if you see your doctor say, like spit out a percentage, it's coming from one of those scores, most likely.
Okay, I'm gonna ask you a tricky question. I know the answer, you know the answer. I need to beat this answer home. Do you have to be symptomatic to be at high risk of sudden cardiac arrest?
Absolutely not. I mean, there are plenty of people that unfortunately present with cardiac arrest because they had no, well, I'm not going to say plenty of people, but there are HCM patients because I don't want people to be out there thinking that that's going to happen to them. But it does happen that people don't know. And the challenging part, and you and I have talked about this before, is you may think you're asymptomatic, but just have never known what it was like to feel normal. That's one thing. But there are some people that have no exercise limitations. You put them on the treadmill and they can go for days, and they have very significant HCM with scar and a lot of obstruction. And for whatever reason, it doesn't affect them the same way it affects other people. And those people might not know. And it doesn't mean that they're not at high risk. And so everybody gets the same evaluation.
We're never going to get to zero risk. There's always going to be some unknowns because it's an evolving science and we're all learning together. But we've identified these particular risk factors and they're really important. But you can't assume because you don't feel it, it's not a real risk. I've lost many clients because they said, I don't really feel like I'm going to die. I don't feel like it. And I can't express enough that you don't have to feel like it. It's going to happen whether it's you want it to or not. If you have these risk factors, we know that better. I wish we had 100% clarity on all risk factors, but I think we know the high risk.
Yeah.
We know the intermediate risk, but there's always the low risk, and that doesn't mean no risk.
Yeah, and I do think, kind of like you're saying, like there's the intermediate risk. There is a very much a shared decision-making aspect of this.
Great topic to bring up. So I'm
Yeah.
planning the agenda for the October in-person meeting, opening for registration in April, just saying. But we're going to do a very deep dive into the concept of shared decision-making because it means one thing to a medical professional. It means something else to a patient. And I don't think we've gotten a really good opportunity to communicate what I think it means and what the doctor thinks it means and what it actually means and how to participate in it in a meaningful way, which is the core of patient advocacy. How do you advocate for yourself? How do you communicate what you want and need? Not necessarily choosing what options are available to you, your anatomy and your family history and all these other factors might be the guidance as to what is available. You don't get to say, I would like to have a defibrillator and that be my treatment, and that's all I want. Thank you, goodbye. There's layering here. So talk about ICDs for that
Totally.
intermediate risk.
Yeah. I mean, it's just like what you bring up, where we would never put in an ICD just so you can play sports and it makes us feel better if you don't meet criteria. And that's specifically written in the guidelines, to not do something like that. But I think when I kind of get more at, well, first of all, I think all of these decisions should be shared. As your doctor, we're not here to tell you what to do. We're here to give you as much information as possible to empower you to make the decision that's best for you. And so I think that, with some patients that kind of fall in that gray zone where, some might say, well, your likelihood of having an event in the next 5 years is 4%, 5%. Could happen. Not a huge risk, but, it could happen. And you look at the other traditional risk factors, and maybe some of them are there, or maybe the family history is a little bit concerning, but it doesn't meet that strict first degree relative had this, but you see multiple other people have died suddenly. And maybe the screening hasn't been as good for you to say confidently that first degree relative doesn't have HCM.
Right.
A lot of times it's not black and white. And so then it's a discussion about what are you most concerned about? What is your biggest fear? Are you going to, I had a patient the other day tell me, I have 2 children. My biggest fear is that when I go to bed every night, that I'm going to have a sudden arrhythmia and not wake up. And their risk is borderline, right? And so it's not unreasonable to consider a defibrillator to protect them. And when they're telling you, these are my biggest fears, then you counsel them on, this is the risk of having a defibrillator implanted, this is the long-term risk, and these are the benefits. And if you feel like the benefits outweigh those risks, then we should do this. But that's what a lot of that back and forth really, and then, on the other spectrum, you'll have like a 75-year-old with apical HCM and aneurysm and a bunch of scar that would meet criteria for getting a defibrillator, but never even knew they had this disease. And they say, you know what, I would rather, if an arrhythmia is the way I'm going to go, I'd rather take my chances than have a defibrillator implanted in my late 70s. Also reasonable.
Closely approaching their 80s, very intelligent individual, said, the scenario pretty much as you've laid it out, apical aneurysm, high risk of arrhythmia. He said, and he's a physician. He was a physician. He said, I just want to talk this out with you. He's like, I know I could do this, but I also have a family history and a known gene for Alzheimer's. And I think I'd rather die suddenly than die of Alzheimer's. And I don't think I want to get an ICD. Am I suicidal? I'm like, whoa, that escalated quickly.
That's a lie.
And I'm like, no, you're just choosing a potential manner of death. And I'm of the mindset that if we can have some choices in how we leave this place, that's okay. And at 80, balancing arrhythmia risk versus Alzheimer's, I might opt to have an arrhythmia as well.
Yeah, I think the discussion should at least be had. And you lay everything out.
He was doing his job and his due diligence as a patient and as a parent, trying to explain to his adult children, these are my decisions. This is what I want for my life. And that's perfectly fine. He said, if I was 25, 35, 45, 55, I'd make different decisions. I'm like, and that's why you have these conversations.
Yeah. So there's a lot that goes into those decisions, and then there's different types of defibrillators. So there's a lot to talk about risk. And I think that whole conversation should take up probably a third of your visit. A third on diagnosis and symptoms, a third on sudden cardiac death risk stratification, and then another third on the genetic aspect and the familial screening. That tends to be like some of the big chunks of my time.
Yeah. Okay, so we've kind of beaten up the ventricle. Let's just talk quickly about the atria. Atrial fibrillation and HCM is complex, doesn't respond like AFib in other people. Some people find out they have AFib first and HCM second. Some people live with HCM a long time and then start experiencing atrial fibrillation. What is atrial fibrillation?
Yeah, so the atria are the two top chambers. If you think about the heart like ice cream cones with the scoops on top, they're the ice cream scoops on top. And so those two top chambers receive blood from the body, and then the blood then passes into the ventricles, and those are the pumping chambers of the body that pump the blood around. And so the atria usually have a very nice normal electrical conduction that goes through and tells them to beat before the ventricles beat. And what can happen is that electrical message can go completely haywire. And things that put you at risk for that happening, if your atria, those top chambers get stretched and dilated, that stretches the electrical system too. And so when you stretch on those electrical systems, they just start going haywire sometimes. And that can happen if you have a really stiff heart, like what happens in HCM. It can happen if you have a lot of obstruction due to what we call anterior motion or systolic anterior motion of the valve, which lets blood go backwards. Those top chambers aren't used to seeing a bunch of blood go backwards. They're not supposed to see any blood go backwards. And so they're constantly being just overloaded with fluid and pressure, which makes them dilate and puts you at risk for stretching them out and having abnormal rhythms. So instead of having that nice normal contraction, the top chambers can go electrically haywire, and instead of squeezing, they quiver. The imagery that someone said to me when I was learning medicine early on was like, it's like a bag of worms. They just do like this. But it's so, forget that. And when they're doing like that, blood can sit there and clot. And that's what puts you at risk for stroke. And so atrial fibrillation and stroke being a clot traveling from your heart to your brain and causing damage to your brain. And so that's one reason that we need to know about AFib and HCM, is because we are just at much higher risk for stroke. And it doesn't matter, some doctors use a conventional risk score for stroke and if you have AFib, that doesn't matter in HCM. If you have AFib, you need to be on a blood thinner. Doesn't matter if you're young or old. There are some caveats, and like if someone has really high risk for bleeding and things like that, that there's a shared decision making. But the vast majority of people should be on a blood thinner regardless of what their other risk factors are, just because we know the risk for stroke and HCM, and it's such a devastating complication of this disease. The risk is so high that you should be on the blood thinner. But that's the one part of it. The other part is most people with HCM do not tolerate atrial fibrillation well at all. And when I was saying earlier about people saying, I went into a funny heart rhythm at 3:30 and I felt bad since then, that's almost always AFib. Like this persistent, I knew when it started and it stuck around, and I knew when it stopped, almost atrial fibrillation every time.
So both my sister and my dad were big AFib patients. And they would get this look on their face. They're like, my father would say, the fish is flopping again. Because he could feel it.
Yep,
and my father was a fisherman. He's like, the fish is flopping again. I'm like, that's my dad's really articulate way of saying I'm in AFib right now.
Yeah.
Which would then have that downstream consequence of, okay, let's take some extra meds. Let's see if we can break it. He would do some tricks with ice and water and plummeting his wrists into cold water to try to shock. It worked a lot. And then he would try some different types of coughs that would work for him. And then we would go to the emergency room and he'd be cardioverted. And he was cardioverted no fewer than 14, 15 times in his life. Yeah. That was Dad.
Oh gosh. Poor guy.
Then, Dad also went on to have a left atrial reduction at the Cleveland Clinic. And Nick Smadera's like, that's the largest left atria I've ever seen. And he was like his right was like 9 and his right was like 9 and left was like 8. How my father's heart held on as long as it did, I'll never know. So they did a right and left atrial reduction. Crazy, you don't hear about
old school.
I know like 2 or 3 people other than my father who's had it done. So dilation of the atria leads to arrhythmias, and it makes you feel crappy. That's an official Jersey girl term. AFib and HCM makes you feel crappy. I
Yeah.
do want you to talk for just a quick moment about the role, if any, and when of a Watchman device. And what is a Watchman device?
Yeah. And so when I was talking about the top chambers of atria being at risk for building up clots, well, one of the biggest reasons they're at risk for building up clots is because the top chamber has this thing called an appendage, which is this like ear-like projection that sticks off of the atrium. Yeah. And so that is at particularly high risk for clot. And so sometimes in patients that cannot tolerate being on a blood thinner, we can use this thing called a Watchman device, which almost looks like a little parachute with metal tines that when you deploy it, it seals off the ear, essentially. Like the appendage comes off the atrium and it's like a circle there, and you deploy this balloon looking thing, but the Watchman sits in there, expands, and tries to seal off the appendage, with the goal being that if no blood can get back there, no clot will form, and that, in theory, you should be protected.
In theory.
In theory. I wouldn't say that we definitely don't just do it for people that don't want to take a blood thinner. That is not, a clear indication to put a Watchman in. Sometimes people just can't be on blood thinners for devastating issues with bleeding and things like that. That is one way of sealing off the appendage to try and decrease their risk of stroke. There's other ways that the appendage can be sealed off. A lot of times when we're operating on patients for myectomies, things like that, they can either snip them off or they can tie them off the appendage to try and decrease that risk. They're all trying to get at the same goal, which is to seal off the appendage.
I bring it up because I recently spoke to somebody who their local doctor is treating their AFib with a Watchman device and no anticoagulation, and it was never even tried. And I'm like, okay, that's not standard of care. That's not how it's typically done. And a Watchman device is not 100% effective against a clot being formed, because you still have a dilated atria, you still have some turbulent blood flow, and you still have the ability of the atria, not the appendage, of developing that clot. So, even though blood thinners aren't 100% effective in reducing or eliminating the risk of clot, but they're really good at lowering the risk exponentially, but not to zero. Correct or incorrect?
You're right. I mean, in other conditions that are, similar to HCM, like amyloidosis, where the atria get really, really big and stiff too. And this can happen in certain forms of HCM, that you can then form a clot in another part of the atrium that is not the appendage. So you're right. We try and do anticoagulation if possible. And then also try and get you out of AFib. Because most people don't like it.
It's a nasty.
That's true. Sometimes we can't.
Sometimes we can't. Okay, so we are kind of heading into the second part of our conversation here, because we talked about some atrial arrhythmias, talked about some ventricular arrhythmias. If you want to hear more about the treatments for atrial arrhythmias, we talked about that in our last podcast with Marty Marin, so you can go pick up that one, and there's lots of information on the HCMA website. But I wanted to take a moment because Alex and I go way back to even before I actually remember Alex, because I talked to his mom first, which is not something that I typically do with physicians that I work with. I don't check in with their mom. But I met mom first, and then we met because HCM is a family thing, right? And HCM runs in families. It runs in mine, it runs in yours. And as we go into April, our theme of the month is knowing your family heart health history and understanding how important it is for family members to be screened. So tell me what you think about when I say family heart health history. Like, what does that invoke for you personally, and then as a physician?
Yeah, it's interesting because I see you'd think, oh yeah, I know what's going on in my family. And it's particularly humbling for me because I see my patients now. My family was no different than anybody else. When we were diagnosed, nobody had HCM in our family. And then all of a sudden, my brother and I had it. And then my parents were checked and they didn't have any evidence of disease. Weird. But then when you look a little bit deeper, and it was actually me sending messages back then, they used to use MSN chat and ICQ and all these different chat messaging things. This is when like I was a kid.
Dating yourself.
Yeah. So I would send these messages to people I didn't know in Cuba and other places where my family was from. And they had been diagnosed with this thing called IHSS. And I was like, okay, what is IHSS? It's
HCM.
HCM. And so, we went from nobody having this condition to like 4 aunts and uncles on my dad's side having it. And no one talked about it. No one talked about it, and the different names were used, which made it even more complicated to communicate. And not everyone was medically savvy about it. And so I think that a lot of that is on the physician when they meet you, that point of contact, to really stress the importance of this is what you have. And a lot of times I'll draw the heart out and write stuff on the back of the patient's EKG, and I
Mhm.
give it to them at the end of the visit. First of all, because most of the EKGs look wonky and you don't want to show up in an emergency room with your EKG and chest pain and them not know what you have. But then
Then
they
you
keep
want
what's on
yourself
the
a
back.
catheter.
That's true. And so, I think it's important so that the physician really imprints on you the first time you meet, talking to your family members about what it is, the importance of all first degree family members getting screened. And that by screening, I mean an ultrasound of the heart, an EKG, and a visit with someone that knows something about HCM. Can be a general cardiologist, but if it gets complicated, sometimes it's helpful for at least that general cardiologist to have a conversation with someone that sees a lot of HCM. But
So
that's what I try
one
to
of
do.
that is one of those issues. Like if you go to a community cardiologist and you say there's HCM, or you use the old words, there's IHSS or ASH or
Mhm,
apical HCM, or you come up with one of the
mhm,
many definitions of HCM. If they don't see a lot of it, they might be able to do an echo. And if you have a very classic presentation, it's easy to find. If your hypertrophy is in the lateral wall, if it's not in a common spot, like it's not in the septum, it's in the apex, but maybe more on the outer wall towards the bottom of the apex, they might not get the images right. And
mhm.
one of the things I'm hoping that we evolve to in cardiology as a whole is better community-based echoes, but a general echo can be done by any kind of doctor. You don't need to have a special license to perform a cardiac echocardiogram. Like you don't have to do that. So you want to know who's doing it, how many images they're taking, are they protocol driven? It's not the sonographer's fault if they don't catch it, if they didn't know to look at the right angles, or the person who's reading it doesn't know what they're reading. It's like
Yeah,
giving somebody a book in English when they only speak Spanish. They'll pick out some of the words, but
yeah,
they're not going to get it all.
totally. Yeah, and I think that the power of going to a center where like a center of excellence, like so for instance, yesterday, I read 12 mavacamten patient echoes, and there were like 6 HCM stress echoes, and then another slew of HCM resting echoes done. Because Anjali was in clinic and I was reading Mava and Teresa was in clinic. And so we probably did more HCM echoes yesterday than most places in the community do in months,
Years,
maybe years. Years. I want to give
maybe
them the
years.
benefit of the doubt. And so, when you see it so much, when the people doing the study see it so much, like I get called all the time, like, oh, Alex, we got another HCM echo. I was like, all right, let's do it. And there, it just makes a difference when you've seen it so many times and you know what to look for, and you can move the probe just a little bit to find the thickest spot. And so it makes a difference, but at least getting the initial screening, like even if you can't come to a center of excellence, to get the initial screening, if the EKG is abnormal, the machine will say it. Like just tell your family to get the initial screening. And it doesn't just stop there, but the initial screening is the first step.
So what do you see is the value of genetic testing in families today?
So, genetics, dating back to the early 90s when the Seidmans, made the first familial genetic diagnosis and started figuring out the genes to where we are now, it's been a huge leap in, our panels. Now you can get combined cardiomyopathy and arrhythmia panels, and they test a lot of genes.
Mhm.
And if you look across all the centers of excellence across the country to see high volumes of patients, I think about 50% of people will come back with a positive test. That have bona fide HCM on imaging, diagnosed with HCM, and they get tested. About half will come back with a genetic marker that we think is very likely to cause their HCM in their family. That doesn't mean that the other 50% don't have a genetic form of HCM, because I have multiple families that multiple people have the disease and they've had panels done from different companies and they're always negative. That just means that we're probably not smart enough to know why genetically you guys have it.
Mhm.
But when you do have a positive genetic test, it can be really helpful in guiding screening for family. It's not necessarily going to change, at least in the state we are today. Maybe at some point it will change how we treat you, but it's not necessarily going to impact my immediate clinical management for the person sitting in front of me. But if you have, let's say, 3 children, and you can test them each for the specific genetic change that you have that caused your HCM, and 2 of the 3 don't carry that gene, that means their risk of developing this disease is the same as the general population. So they're not at the same risk as your son or daughter that does carry the gene. And so the screening, the lifetime surveillance, that changes, because if you have that genetic risk factor, we're going to be watching that kid, because at some point it's not 100%, but
Mhm.
it's possible that they could develop HCM, and then that way we're ready. So it makes a difference there, and
And
for
Tom,
family planning.
a perfect segue. Did you read my mind, Alex? We're getting good at this. I spoke to a young man yesterday. He's in his mid-30s. There's a question as to what his path forward is going to be. It may include a transplant, it might not. We're not sure yet. And I asked him, have you had genetic testing yet? And he's like, well, no, because I know what I'm going to do. I said, well, are you planning on having children? He doesn't have siblings. His parents are not in the question right now for other reasons or whatever. But I'm like, are you planning on having kids? He's like, yeah, I think I want to have kids. I'm like, do you want to have biologic children? He said, I think I do want to have biologic children. I said, well, there are pathways that you can use to have a child in an HCM family created with PGD, pre-implantation genetic diagnostics, that the child may not have to have HCM. And he went, I didn't know that was possible. I'm like, and that's why we're talking today. So now he's going to go get
Yeah.
genetic testing, and then he can have that conversation with his partner. Do we want to do IVF and PGD to try to have a child that is free from hypertrophic cardiomyopathy?
Yeah.
And just the fact that that's a possibility today is amazing, but you
Yep.
have to know your gene to know if you can use that or not.
Yep. And I had a long conversation, because I've had this conversation with so many patients recently, because I've just had a slew of young people. And I had a long conversation with our genetic counselors about this, because there's a lot of counseling that goes into that process. And one thing I try and really impart on the families is that there's not necessarily a right or wrong answer,
No,
and
there's
there
not.
shouldn't be any guilt, in saying, you know what, I don't want to do this. Because on the flip side, you wouldn't be here, I wouldn't be here if our parents did that, right? And
True.
and so it's a very much a decision that's up to the person. There's no right or wrong. But it in my opinion is a crime if people don't know it's an option.
We agree 100% there. To know all of your treatment options and all of your life options are
Yeah.
critically important. I remember, and I'm going to go back here to like the second HCM International Summit. Barry Marin held it. It was in Minnesota. And a gentleman from the Philippines came with a picture of his child who had been created with PGD. We had not had a confirmation whether or not the child was truly HCM free or not. It turned out later that he wasn't. because they were only at that point like 60% effective in, embryo selection. So it didn't work in that child, but we've used it in others and it's worked very well. But I'm going back now to like 2002, 3, so early technology. And this physician came out to talk to me at the break, and he said, "Are you not incensed by that voodoo magic that they're doing with trying to create designer children?" And I said, "No, I think it's pretty awesome. And if I had the opportunity to not give HCM to my daughter, I might have taken it up. But that was 1995. And it's, I like that my kids may not have to have kids with HCM if they so choose to use those pathways." And he said,
Yeah.
"But you wouldn't be here." I'm like, "Yeah, but somebody else would be here." And,
Yeah. Yeah.
I don't think I'm that important, but that's okay. But that's my thought. That's
Yeah.
my thought.
And so I think having an honest, thorough discussion about it is an important part of the genetic counseling, because that is also that affects the rest of the family.
It
You
does.
know,
And it can help uncover some of those medical mysteries that you didn't quite understand. And
that's true.
there's so much knowledge. And what the future holds, we were discussing earlier, there's a lot coming down this pike of genetic therapies, genetic treatments, so much so that on March 15th of this year, the FDA opened up a brand new office to strictly manage the influx of new genetic therapies that are being developed. So the FDA had to set up a whole new division. I'm going to get you the proper name here. It is called Establishment of the Office of Therapeutic Products. And under that new division of the FDA, or that new office of the FDA, there are 6 different offices, each with multiple divisions. So genetic therapies are being developed for other diseases, not just HCM and whatever, but our country is starting to tool up to be able to address the needs of this particular community. So of genetic therapy. So it's coming. We should all become educated and we should all become aware of what's happening. Do you have any thoughts on what's coming?
Yeah, there's been a lot of interest in it. The idea being that if you have a genetic form of this condition, that we know the gene, and you inherit one copy of a gene from each parent, and all it takes with HCM most of the time is one abnormal copy. And whether it's that gene then is not making a normal amount of protein, then the idea behind some of these therapies, or a normal protein itself, the therapy would be to replace that gene and to make that gene work appropriately. That's an incredibly simplistic way of portraying it. But if we can then make your body create a normal protein by making the gene normal, then maybe it can help your disease. And I think there's a lot of very interesting, fascinating work that's especially being done in conditions that otherwise, would be fatal. And so I think that there's going to need to be a lot of thought going into patient selection and who the right people are that are going to be selected for these kind of therapies, and making sure that everyone is truly aware of the risks and benefits. But it's like you said earlier, it's coming. And so we have to be prepared, and we all need to be involved.
We all need to have our voice at the table, and you'll be hearing more about that. I'm gonna kind of wrap up today's conversation with a little bit of an announcement for some people that they'll care about and others won't care about it so much. There was also another notice from the federal government yesterday that there is going to be a major shift in UNOS, and they are going to basically break up the monopoly of UNOS as a nonprofit. For those who are unaware, UNOS is the organ procurement, or basically they're the governing body of how organ transplantation is managed in the United States. However, they are a nonprofit organization that is a quasi-governmental agency, meaning they receive most of their funding from the federal government, but they operate actually under the same structure as HCMA. It's a 501c3 nonprofit, but there have been some problems with technology and delivery and communication that were the feature of a public meeting in front of, I don't know if it was Congress or Senate, last fall. I participated in that meeting, and the findings of the committee were that they need more infrastructure and they need to be more updated. And the current administration has put forward I think, $65 million proposal to overhaul the entire organ transplant system in the United States. It would encourage better transportation documentation. You can track your pizza from Domino's to your house, but you can't figure out where the kidney is in transport. And they've lost multiple organs. So you have somebody sitting there waiting for a kidney to arrive and it's literally gone. There's stories of them getting run over by delivery trucks. There's terrible, terrible stories of wasted organs. And a large number of organs that are available are not utilized because our systems are too slow and antiquated and old. And the government has stepped in and said, we're going to put some resources here and clean up the system. So it's not going to impact anybody who's currently listed today. We're going to keep the programs running as they are, as they develop new ones. So you're going to probably start to see some news coverage on this. So if you're a transplant pathway patient, don't panic. We're on that one too, and we're going to keep you informed as things progress. So, Alex, any final thoughts for this third time you're joining me on podcasting?
I think since the bulk of what we discussed, a large part of it was arrhythmias. I think the one thing I want to leave the conversation with is if you do have a lot of arrhythmias, particularly like most people think about the ventricular ones similarly, but the ones from the top chambers, the atria, don't be afraid to get second opinions on, going to centers that do a lot of interventions for atrial fibrillation and flutter. Recently, we had an HCMA talk with our center, and I had patients asking me questions about very specific questions about well, we've done this and this and it didn't work. What's the next step? And so I would implore you to consider, if you live near a large center that has a lot of electrophysiology, those are those doctors that do these procedures to try and get people out of AFib, like ablations. I would put in a plug for getting another opinion too, because sometimes there's certain technologies that are offered in one place and the other that could maybe get you out of AFib. And, a life out of AFib with HCM is probably a much better life than in it. It's not, sometimes we just can't get you out of AFib, but that would be based off our arrhythmia discussion. One of the things I would think about is just make sure you're plugged in an electrophysiology program that does a lot of ablations and sees HCM. I
will add to that if you have financial difficulties and you cannot get to a center, the HCMA has the Lori Fund. You can apply for a travel grant, and we'll give you up to $600 a year in travel funds, which is typically enough to pay for a plane ticket, a night in a hotel, a train ticket, gas money. We don't want you to say, I wish I could, but I can't get there. We will do what we can to help you get there. We will do what we can to help appeal to your insurance company that you should be allowed to go out of network. We will be there for you. That is what our job is as advocates, is to help you get to those care models that can provide you with the best therapies and outcomes. So don't suffer in silence, and don't let your pride get in the way of applying for a grant. The money is sitting here. I want to give it to you. We've raised the money for you.
Yeah.
Please come apply and take it. And if you have resources and you think, wow, that's really great, you can donate to the Lori Fund right on the website. So we can do that both ways. I will wrap with asking everybody to join us this evening, where we will be having yet another Big Hearted Warrior tour. And we will be featuring a smaller program that some of you may not have heard of yet. It is in Rochester, New York. It is Rochester Regional. Dr. Bipul Baipav, which I just love saying his name over and over again. Bipul Baipav. What a great name. Took me a while to pronounce it properly, but I just think it's very poppy. So he is the director of the program with the awesome name. And he's a lovely individual. I actually helped set him up on a mentoring process with Harry Lever, who basically has taught him the tricks and tips of 40 years of HCM echo reading. So we all love Dr. Lever. So we're going to be meeting with Rochester Regional tonight. It starts at 6:30. If you haven't signed up yet, you can still do so. And we've got some other programming coming up next month. We're going to be talking more about clinical trials. We're going to talk about clinical trials in the myosin inhibitor space. We'll be meeting with Cytokinetics to talk about, oh my God, what Sequoia? I'm like, which tree are we talking about this time? We're talking about Sequoia. They got a thing for trees over at Cyto, and they name all their trials after trees. So we have Sequoia, and then we'll touch on maple, and then forest is the whole conglomeration of all of them. So they're great trials. We want to make sure everybody knows how to access clinical trial information. And that's pretty much what's going on today. Oh, tomorrow morning. This is not a normal podcast time. Friday's my podcast time, but Alex is special, so we put him in on Thursdays. But tomorrow I will be meeting with an author of a recent publication on diet and exercise in HCM from NYU. So join us tomorrow morning for an enthralling conversation about why weight management is really important to our community, and we all need to kind of focus on it. No shaming anybody. It's a challenge. And there may actually be reasons why it's a little harder for people with HCM to drop weight than other people. And we're evolving in our knowledge of metabolics and how our hearts use energy and how that might play a role in why it's a little harder for some of us to shed those pounds, even after they take the heart out of your body. I don't know. All right. I'm a 50-something-year-old girl. These things happen to us. We get a little chubby as we get older. You won't know these things, Alex. You don't have to go through menopause.
Thank God.
Yeah, thank yourself for that one. Additionally, as I have brought that topic up quick, I want to hear back from you. We've had some requests for some different types of discussion groups. Give us some feedback. I've been asked to hold a session on sex lives of those with HCM and how to have normal sexual relations. And I don't want to not discuss things that some people giggle about. We can giggle about it too, because, it's always fun to giggle about these things. But we've been not getting more questions on that one. So I'm looking for a male to partner with me in a couple discussion groups. Alex, let's think about that.
Sure.
Okay. Well, I just nailed that one down, people. Okay. So we're going to plan that. We're going to plan that, and we're going to have an open and honest discussion about sex lives and HCM. So that's important too. There's more coming. Lots happening. October 21st. Mark your calendars. Come to New Jersey. Plan on being here. We're going to go back to an in-person meeting. We're going to get all of our big-hearted friends and colleagues in one room and have deep discussions and move the ball forward and get everybody involved in this community, because people, you are part of a very unique community, and we want to continue to build the community. Alex, my dear, thank you so much for joining us today from your basement. I love the artwork behind you. It shows me that you really are a doctor, because no, the other one looks like organs.
That's Tennessee. Side. That's Vanderbilt. And that's a heart.
And that's a heart.
Lungs.
Yeah. Yeah, that's
normal thickness, but we won't hold it against it.
Okay, well, boring. Alex, thanks so much for joining us, and thanks to everybody on Facebook for watching. This has been Tales from the Heart, a podcast from the HCMA, brought to you by our wonderful sponsors at Cytokinetics, Bristol Myers Squibb, Tenaya Therapeutics, and Embria Pharmaceuticals. So thank you all for your support of this and other programming at the HCMA.